Good morning. Welcome to the latest in our series of joint Kaiser Health News, Health Affairs, Health Policy Newsmaker Breakfasts. My name's Alan Weil. I'm the editor-in-chief of Health Affairs. We're the leading journal at the intersection of healthcare, and policy. Running the show today will be Julie Rovner, Robin Toner Distinguished Fellow at Kaiser Health News. You all know her from her 16 years as health policy correspondent for National Public Radio. The star of our show today, the reason you're here, is Sylvia Burwell, who's the nation's 22nd Secretary of the Department of Health and Human Services. As you know, she came to HHS after serving as the director of the Office of Management and Budget, with previous stints at quite a few places, but most recently as president of the Walmart Foundation and president of the Global Development Program and COO of the Bill and Melinda Gates Foundation. We're pleased to co-sponsor this event, and I'll now hand it over to Julie to get the program going.
Thank you, Alan. Good morning. Thanks, everybody, for being here. Thank you, Madam Secretary, for being here. I'm going to ask moderators opening question, and then I'm going to open it up to the audience. We do have TV cameras here, so please wait for a microphone to get to you before you speak, and please identify yourself and your news outlet when you ask a question. Madam Secretary, I think pretty much everybody in this room still has PTSD from last year's open enrollment. What can you say to reassure us that we won't be having a Groundhog Day when November 15th rolls around?
Well, in terms of that, I will also remind everyone that a year ago on this date, I was still running a government shutdown in terms of these questions of PTSD. With regard to open enrollment, I might start with a little bit of a broader lens and come to that issue specifically. And first, of course, want to thank Kaiser, and thank you, Julie, for moderating today. As I also should mention Ebola. I think for me to be here, I'm sure we will have some questions about that issue, but it is one that we are working on deeply at the department and have been for many months, actually, in terms of the issue, working across the department from the Office of Global Affairs, where we have someone actually embedded at WHO from the HHS team to make sure that tie and lash up is occurring in Geneva, to all the work that you all are familiar with that CDC is doing. The preparedness at home, and attacking the epidemic at its center in West Africa. And when I mentioned that before we move into the Affordable Care Act, which was something that I knew when I would be coming to HHS that I'd be working on. And I'm at the end of my first 100 days, basically. And as I've gotten to the end of those 100 days between Ebola and the fact that there were 12,000 children in the care of HHS when I arrived with the unaccompanied children, I'm a little bit reminded of a point in time before when I was in the Clinton administration. It was when it was announced that I would be Deputy Chief of Staff to Erskine Bowles. And Helen Thomas, who many of you in this room probably know, found Erskine and said, "Erskine, don't you think Sylvia's a little young for this job?" And Erskine looked at Helen Thomas and said, "Ellen, in this place, a year is a dog year." And I'm sure you all realize that I'm reminded of that story not because I'm young anymore, in terms of what my first 100 days. But with regard to the Affordable Care Act and how we are thinking about that and being ready for that, it's obviously one of the top priorities. When I think about the Affordable Care Act, I think in terms of three measures: quality, affordability, and access. And this particular question about healthcare.gov and the marketplace is deeply focused on access. I think it's important, though, to recognize when we talk about access that the most important measure there is the reduction in the uninsured. With regard to the access question, that's why the legislation was passed. When we think about what is the measure by which we should judge ourselves, it's the question in the reduction of the uninsured. The marketplace is a very important means by which we get there. So is Medicaid, so is employer-based coverage. And so with regard to the marketplace, as we go into it, I think there was a conversation even here yesterday about these issues. There were a lot of lessons learned. And those lessons were both positive and negative. In terms of some of the positive things, we learned a lot about how the consumer behaves and reacts in terms of the consumer works up against deadline. We learned a lot about the importance of sound technology. And from those lessons have put together a plan that we are working on every single day and have been since the day I arrived and before I arrived, As part of that plan, there have been a number of pieces. One, prioritization in terms of making sure we have a prioritized list and deadlines that we're meeting on a day-to-day basis. Second, I think many of you know that we have focused on management as a part of that going forward. Many of you, I think, yesterday had an opportunity to spend time with Andy Slavitt, as well as Kevin Cunahan and Lori Lotus. Those are all three new additions to an already strong team that we brought on. And finally, we are obviously very deeply focused on technology. So continue to make progress every day on this issue, and are looking forward to continuing to do that day by day. We're deeply focused, as I think you heard yesterday, in quite a bit of detail.
Well, before I get to the audience, I have my own question, which was that last month the GAO put out a report that suggested that the plans were not necessarily doing a good job letting people know when there was elective abortion covered. This was obviously one of the last issues settled when the law was enacted. There's supposed to be one plan that doesn't have abortion coverage, one plan that does. Apparently that's not necessarily happening. What is the department doing to make sure that that all gets straightened out?
So first, I think it's important to reflect that with regard to the federal law and the issues of federal funds, there are no federal funds being used for abortion except in the cases, as the law states, rape, incest, and questions of life of the mother. And I think that's an important part in this context. With regard to the issue that's been raised, it's one where we believe we need to make sure that the law is being enforced. And right now, CMS is working on the ways that we're going to communicate clearly with both states and insurers so that there's clarity about what the law is in this space.
Will this be straightened out for this open enrollment?
With regard to the question of this open enrollment, working through, the plans are in place. For the most part, we're finalizing those plans. So in terms of how the communication is going to work, we'll have to see how quickly we can get the communication out and where we are, because I think the GAO report was actually based on a previous year's plans, not this year's plans.
It was. Okay, let's go to the audience. Right here in front. No, wait for the microphone.
Maureen Groppe with Gannett and the Indianapolis Star. You met with Governor Mike Pence on Monday to talk about his alternative proposal for expanding Medicaid, and he said that there were still disagreements after that meeting. What are the disagreements, and how confident are you that you're going to be able to reach a deal with Indiana to expand Medicaid?
With regard to the issue of Medicaid and Medicaid expansion more broadly, I think everyone knows that there are 27 states plus DC that have done the Medicaid expansion. We are in conversations with a number of states, as has been purported. And each of the states, as we think about this issue and are working with each state individually, there are really two things that are the guiding principles of these conversations. The first one is that it is important to listen and hear the needs on a state-by-state basis. And the needs of Indiana and how that governor is approaching it are actually different than Tennessee, which has also been reported, and Utah, which has also been reported in terms of my conversations with those governors. The second issue, so we have to think about what flexibility they need and what they think is the best approach for their state. The second thing is that there are some core parameters that are both statutory and policy in terms of what Medicaid needs to provide. That's where we're having the space of the conversation. We're continuing the conversation. The governor and his team and our team have been working on over a period of a year in good faith on this effort. I think everyone is coming to the table with a real desire to make progress, and we're going to continue to work on that.
Here. Wait for the microphone.
Thank you. Athena Jones from CNN. It's a compound question. You touched on Ebola, so just on healthcare signups, do you have a goal that you can share for this year in terms of number of signups, and I guess alternatively the number of reductions in the uninsured? Is there a target goal? And then on Ebola, we all know that this temperature screening at some of the airports, major airports in America, is going to start. But what do you say to people who argue that this is, in some cases, all sort of for show, to calm the public's fears, since many, many people could still make it through given the 21-day incubation period?
So with regard to the first question about our goal is for the consumer to have a quality experience in our open enrollment period, and we will continue to try and move those uninsured numbers and to maximize our ability to do that. With regard to the question of a specific goal and the numeric goal, one of the things, and there is a CBO number that exists, a 13 million number, that is based on a trajectory that eventually gets to 25. And I think one of the things that is different from when that number was originally put out is now we actually have information about what happened in the first open enrollment. And so how one thinks about the slope of that line over a period of time is something that we are analyzing and working on from this perspective. A top-down number is how you get to reaching a specific number out there, but now we have data and information, and we want to try and build that number bottom up based on what we know both of those that did enroll and information we learned from that. So that's something we're continuing to work on with regard to that specific question. In terms of the issue of Ebola and how we are thinking about the issue of homeland preparedness and making sure that we are ready as a nation, as I think has been made clear by Director Fauci or Tony Fauci or Dr. Frieden, the important and most important place with regard to taking care of screening is actually at the point of departure. And that's been in place for many months, and as we know, we have a case, and that case sadly is deceased. But for many months did not have a case that entered the country. And that screening, we know that that screening has worked in the sense of 80 people have been pulled from the lines in the screening and stopped in the home country. That's the most important place for us to do that. The next step with regard to preparedness, as we've discussed, is having a system that can handle any case that we have. And we've had one case, and I think there may be other cases, and I think we have to recognize that as a nation. And that's why the preparedness of our healthcare system, and whether that's the fact that 8,000 healthcare providers have been on CDC webinars, or the fact that literally hundreds of thousands of healthcare workers have been communicated through our Health Alert Network and the 7 separate directional documents. Those are the most important steps. At the same time, we continue to evaluate and add steps that we think are helpful both to fight in West Africa and to care for our people. The question of the screening that we'll be doing at this period in time, there are a couple things that we know and believe, and that is it's the importance of asking the question, how a person may answer a question at the point of departure versus a point of entrance may differ. The second thing is, it is true, it is a period of time of travel. There isn't, and I don't think we're making a claim that anything is 100% secure, but what's most important is we know how to contain, and that is detect, contact tracing, isolation, and treatment. And that was what was implemented, and we've seen implemented in Dallas in terms of the tracking of the folks. So we will continue. And yes, confidence is an important thing, but there is also what will happen in that period in terms of the questioning and what will happen in terms of that period of time when a fever could occur. Yeah. Oh, sorry, sir.
Back over here, right here.
Hi, thank you. Chuck Ross from the Post-Dispatch in St. Louis. Another open enrollment question. As you know, there were 3 facilities around the country that were processing paper applications during open enrollment. One of them was in suburban St. Louis, and there were allegations there that there was little work being done there. I'm wondering if you can talk a little bit about, have those situations been cleared up, have they been fixed, and have you gotten a better sense of paper versus online applications as you go forward in the new open enrollment period?
I think what we are hopeful is that we want things to happen and occur online as much as possible in terms of, but one of the things we're focused on deeply is the consumer and the consumer experience, and want to make sure that we have alternatives and places for the consumer to go, and whether that's consumers' ability to work with navigators. Some people want to work with a person to do this in terms of this is new and they need help. Other people want to go directly on. For example, yesterday we previewed 2.0, which is actually out and in the space right now in terms of the special enrollment period. And we think that tools like that will help people who want to do it online do that more. So we would like to see more people online. We will continue to work to ensure that consumers have different needs. There are consumers, why it's on a mobile app is because we know that many of those young people that are in that gap use mobile applications. That's why we've tried to move that to a mobile device. We also know that in terms of the Latino population, that actually there's deep penetration of smartphones, deeper than the penetration for the nation as a whole. So what we're trying to do with regard to the question of open enrollment is make sure that we're serving the consumer the best that we can in 2 forms. One, operational technology being sound, and that gets to the questions that were discussed, I think, yesterday about testing, and the other is as much consumer ease as we can. Will there be imperfections? Yes. Things will not be perfect. But I think what we do know is that we are aiming for a strong consumer experience, and it will be better.
Over here and back.
Nancy Metcalf from Consumer Reports. We saw in the first open enrollment period a lot of people signing up who really had low health insurance literacy, and a couple of problems I saw crop up. One was people who would have been eligible for reduced cost sharing silver plans never knew it because they never got past the first screen of bronze plans and ended up with plans with much higher deductibles than they were really entitled to. And the second is the inability of people to really, and this is not a surprise, it's been talked about before, really figure out who's in their networks. And I just wondered if you have made or are contemplating making any improvements to those features of the user experience.
So with regard to, we are working across the board in terms of that user experience and making sure that people are educated about how to go on and how to shop. I mean, one of the things is this is a complex space to begin with, and you mentioned that many of these people have not been in the market. I think if I went person by person and said, what is your premium, what is your deductible? What is your monthly premium, what is your deductible? The people in this room are the single most educated people in the nation with regard to healthcare, period. You all are the people that write about this every day. You think about this every day. And for me to even go through and tell me your copay for every single individual, I think we might have some gaps in terms of each of you. And so I think we have to put this knowledge question in the context of where we are as a nation. I think we believe that the marketplace is going to hopefully move those individuals you're talking about, but I think this question of us as a nation and how educated we are, which takes us to an important issue, which is the issue of making sure that we have high quality care and affordable care. Some people call that delivery system reform. But so we are working to do that. In terms of the ways that we're working to do that, our stakeholders are an important part of that education process. Having met with them myself several times, whether that's Enroll America or the groups of stakeholders, that as we talk about and as they are doing outreach with regard to enrollment, there are two additional pieces of outreach they need to do, enrollment and re-enrollment. But they need to do use and shopping, education, and the other thing, and that's on the website for the marketplace, but the other piece that is an important thing that's the next step is making sure people know how to use the care. And I think that's another part of what we're doing. With regard to this question of access to providers, we are working with the insurers to make sure that when you click through in a plan, that there is a place where you can click to get to that provider list to try and create some ease. I think this is a place where we're all going to make steps. We're trying to make steps step by step as we go, but I think your point actually is about the marketplace, but it is a broader point.
Go over here.
Sarah Hansard with Bloomberg BNA. Are you tracking the number of policies that are being canceled because they're not compliant with Obamacare? And what are your expectations for getting a more normal risk pool this year?
With regard to the issue of cancellations, that's an issue I think you probably know that last year we put in place a policy that would leave both states and insurers with the choice of extending till 2016 as a transition period to try and create a place of transition to get through the issues that were raised last year. At this point, a couple of things. One, we obviously think the number is going to be a much smaller number than last year. I think we need to recognize that the issue of cancellations, again, in the marketplace before the Affordable Care Act, there are policies being canceled in employer-based care. Insurers do that. And so there's the question of what's happening in the regular marketplace and then those plans that need to come into compliance with quality health plans. We believe we put in place an alternative for transition. We are working with insurers, so where there are those situations, do they have another plan that is an alternative plan, and are they communicating that clearly? So working through the issue, I think that there will be a smaller number this year.
issue of the risk.
With regard to the question of the risk pool, I think when one sees that we have a large increase, 25% increase in the number of plans and insurers coming in to the system this year, as we announced recently, I think that is a reflection of the question that the risk pool is something that obviously the insurers believe is a risk pool that works for them economically, or they wouldn't be entering and putting plans in the marketplace.
That's over here, in the back.
I'm Jim Landers of the Dallas Morning News. I had a question about the transparency initiatives of the department. You've just put out an open payment system for the links between doctors and pharmaceuticals and medical device companies. You've had on the web for some time now Medicare inpatient and physician charges. There have been problems with the open payment system on the drugs and device links in the last week, but as far as the other ones go, the hospital systems say that charge masters really aren't relevant to anything that's actually paid in the hospital system, so it's not really a good indication of what those prices are. What are you doing to strengthen the transparency that CMS is providing the public about these things?
So continue to work and respond to comments. As you mentioned, when we put the first set of information out, one of the things that we heard was making sure that the information has context. And so when we did the most recent release, tried to provide more context, both in terms of the release and anything about that. I think the issue of transparency, when we think about where we were 4 years ago with regard to the question of transparency, and it goes back to our consumer report question a little bit, the issue of what kind of transparency people have even about benefits in their plans, and the transparency that people have now that they know that what a qualified health plan is and what those benefits are, and those being clearly stated. Across the board in the healthcare space, and whether it's around the provider information, around the consumer information, we are trying to move on all fronts. It's also related to electronic medical records in terms of the transparency that an individual can actually have about their own healthcare. And so with regard to what are we doing, we're working actually on all fronts in terms of trying to move the information forward so that both consumers and providers have information that they can make decisions about, and that we create a transparent marketplace where decisions are made. Can we improve it? Should we improve it? Yes. When we hear the feedback on this most recent elements of open enrollment, we want to do that. One of the decisions that we had to make, and I had to make the decision, is the information was imperfect. In the most recent rollout, there was data that was not as clean, and so we had to present some of the information, couldn't present exactly all, but made a decision that it was better to get out a large portion of the information so that we can continue on this path on transparency. The transparency path, because it's new to everyone, it's going to take us time to get there. We need to continue to evolve. But we think it's an essential part, coming back to a point I just raised, which is the importance of information to decision making, to getting to a place where quality and affordability, we drive towards that, and that is about delivery system reform.
Back over on this side, right here.
Hi, this is Philip Klein from the Washington Examiner. I have a question related to the risk corridors, which is that a few months ago you had issued guidance on the risk corridors saying that if the in-payments weren't enough to cover the out-payments, that the HHS would find other sources of funding subject to appropriations. And as you know, the GAO just released a legal opinion recently saying that basically that depending on which language Congress adopts, that HHS won't be able to make payments unless essentially the appropriations language allows for it. And so I just wanted to get your understanding of whether or not HHS will be in a position to make payments in fiscal year 2015 if Congress doesn't put in language allowing it.
I think that there is a distinction between what happens at the end of the program and the current approach we have to the fee-based structure that the GAO was talking about. And so with regard to, we don't have concerns in the upcoming year. And as we've said in what you're reflecting earlier, we will work with the Congress if there are needs in terms of this question of appropriation. So don't think it's a question that will need to be faced right here in 15. If it ever does become a question, I think we've been clear, we'll work with the Congress on any additional language that we need.
Back over here, Maggie.
Maggie Fox with NBC. Your style and the style of your predecessor has been very different in terms of handling crises than the previous administration. You've had to deal with the crisis of the rollout of Obamacare and now the crisis of Ebola. I remember during the Bush administration, HHS was very much in front. You're taking a back seat this time. Are you happy with that strategy, and will it continue?
I guess I would start by saying I would like to understand definition of a back seat. I've had an Ebola meeting every single day since July 28th. I usually have 3 a day.
Can you tell us about that? Because the face to the public has been Tom Frieden, who people know and trust, and Tony Fauci, who people know and trust. We haven't seen Secretary Burwell.
So with regard to the issue of Ebola, I think everyone knows the nation is frightened, and people are frightened of this disease. They're frightened because it has a very high mortality rate. They're frightened because they need to learn to understand what the facts are about that disease. In thinking about people and trust and who you want to hear that information from, Tony Fauci has been working on this issue, as he said on Friday, I think he said 38 years in terms of his work on this space. Dr. Tom Frieden has been, whether it's his work in New York or his work at CDC, and when one has such high quality, experienced physicians and infectious disease experts, Dr. Frieden also has an MPH, a Master's in Public Health as well. For me, that's why I questioned what you meant. I think what you're suggesting is who is on camera often versus the question of deep work on the issue is something that I consider my responsibility and do, and whether that's on a day-to-day basis, making sure that our teams are working on this issue internationally or working on the domestic preparedness, that is something that I consider my responsibility. With regard to the voices on a day-to-day basis, I think it is important to have the experts that we have and we're lucky to have in our federal government working and speaking about the issues.
Back over here. Okay.
Jay Hancock, Kaiser Health News. We've written a couple stories about HHS's minimum value calculator, which, as you know, is certifying as minimum value plans for large employers which do not include hospital benefits, while at the same time foreclosing the employees who are offered these plans from getting subsidies in the exchanges. And a lot of people are wondering if this is something that the administration intended, and so far we've had no answer. Can you talk about that?
This is an issue, I'm going to be honest and say, not familiar with this one in terms of the minimum value calculator and that. I think the one thing I would say is I think the issue that the administration is deeply focused on is making sure that people have access and the issue of affordable and quality access. So within that context, something.
Well, these folks they don't have access. These plans don't have hospital coverage. Can I get back to somebody in your office about that?
We're happy to follow up.
And who should I be in touch with?
I think right now Ben, right here, will follow up with you.
Okay,
Ben
great.
Moroka.
Thank you.
Mm-hmm.
Over here. Rebecca.
Hi, I'm Rebecca Adams with CQ Roll Call. I have an Ebola question and a Medicaid question, actually. I wondered, since you are so deeply involved in the Ebola issue, can you give us an update on the work that's going on at NIH, or whether there'll need to be an additional deployment for CDC and Public Health Service people overseas? And what do you anticipate in terms of needed funding that you may need to ask Congress for after the CR expires? And then my Medicaid question is about the backlog, which we've seen in applications. States such as California still have an enormous backlog, and I wondered if you could address that.
I'll do reverse order. With regard to the Medicaid backlog, that is something that each state and the reasons in each state are different. And so that is something that we actually have to work. It is retail. And so we work state by state by state and are working through that on a state by state basis, continuing to work with the states on their plans and how they're going to do that. I think many people know we sent certain types of letters to different, if you follow the issue, you probably know that we sent those letters in terms of sending clear signals about the level of import, and we continue to follow up. As I said, it is retail. Because each state actually varies as to why there are issues in the backlog, and we are working on literally a state-by-state basis to clear it. With regard to Ebola and where we are, I think I welcome that someone has brought up the fight in West Africa, because that is where this has to be taken care of. That is what we need to do, and that is where there isn't the public health system in place to implement the things that we know can contain Ebola. With regard to the progress that's being made, I'd also reflect that when you look at Nigeria and what Nigeria was able to do in terms of their capability to contain, that is a place where we have seen it work, and we've seen it work in a developing world system. Certainly Nigeria had also the advantage of there was a lot of polio infrastructure that was transferred to be used in terms of the contact tracing and some of those efforts, and had experience in terms of emergency operation centers and those kinds of functions, and we see that. With regard to progress on the ground, I think, as you know, the U.S. military, this started with the largest deployment for CDC. We also have the largest DART, which is the disaster and response teams that we usually use that are led by USAID, and now have brought in the command and control that comes and the logistical capability that comes with the United States military. They are on the ground. Progress is being made in terms of the construction of Ebola treatment units, in terms of the construction of the 25-bed medical unit, which is an important part of attracting healthcare workers from around the world to be willing to come and serve there. Continuing to get the training up and working, which DoD is doing, and DoD has also already deployed labs. Several of the labs for the testing, and that's an important part of the detection. So continuing on that line, at the same time, we are also working with the countries and WHO on doing community-based care. It's not a full Ebola treatment unit, but during this interim period, while we are getting those up and running, and for people who may not have access, making sure that there is community isolation. And so that is the other piece that's being worked on. There has been progress on burial. And I think, as everyone is sadly focusing on here in the United States today, the issue of Ebola spreading even through a deceased's body is an important one. And that is being clearly taken care of here in the United States. But with regard to making progress there, that's a place where we're making progress. And that has to be a behavioral change. Because for many, the burial process, which is a cultural issue of how you treat your deceased, generally involves touching. And that's something that we've had to work through, but there is progress being made. The numbers are going to increase before we can get to a leveling off point. But right now, what is most important is that every day, those on-the-ground efforts, that there is urgency. It is about days. Every day makes a difference in terms of the number of cases that are contracted. And so there's great urgency on the ground. At the same time, I think we're all very focused on the urgency here at home and making sure we're prepared. And yesterday, I think you all know, the President did a call. I was on the call with governors and elected officials across the country. Dr. Frieden did another one with state health officials. The urgency on both fronts, make sure the country is prepared, but we have to work every day to make sure that we are standing up the capability for these three countries to handle this.
Good morning, Alex Wayne from Bloomberg News. I wanted to ask about the other plague that's in the news right now, and I think the one that's a little scarier to parents in the United States, particularly Enterovirus. What does your department know about how this outbreak began, And what is your department doing to develop either treatments or understand any linkages to paralysis or other serious outcomes?
So CDC is doing its traditional tracking and working with health departments across the country to understand when there are cases and make sure that the appropriate testing to understand when there are likely cases, whether it is that virus or not. And so that's step one. And we are doing the tracking that we do in terms of the numbers and the numbers by state and the numbers by locality so that we have an understanding of that. The other thing that CDC is doing is communicating clearly about the things that we believe are most important. And I would just encourage everyone in this room to step up your hand washing, and if you have children, to make sure that you are encouraging that kind of hand washing. That's one of the most basic things, but it's something I think, before the meals, before everything, making sure that we're doing that. CDC's communicating that. The last part, and I think it gets to the core of your question, is CDC is working with the individual health departments to do the investigatory work to understand in these cases whether it's the question of paralysis or the question of death, is it directly related to the virus or something else? And so we are part of that investigative process to determine those things. So CDC is doing its traditional work that we do with public health, while, as you're appropriately reflecting, there's much focus on the Ebola issue. Our teams are deeply engaged in this issue.
Are you trying to determine the origin of the outbreak at all?
That's a question I would defer to Dr. Frieden.
Over here, Mary Agnes.
I'm Mary Agnes Carey with Kaiser Health News. Just a couple questions about healthcare.gov. You talked about how public responds to deadlines. What are you doing with the site to make sure you won't have problems when you have a lot of demand, particularly at the beginning of enrollment and at the end of the enrollment? And could you talk a little bit about the building of the back end? That has been a problem before.
So with regard to the question of load, that's something that I think was spoken to a little bit yesterday by Andy Slavitt, which is we're doing a lot of different kinds of testing, end-to-end testing, which is something that I think most people that's what most people focus on. But one of the types of testing we're doing is load testing, and that is about trying to test the system with different amounts of volume to try and address the issue that you are raising and to make sure that we're appropriately prepared for surges that would occur. With regard to the issue of back end, as we work through, there were a number of things the back end, parts of the back end worked in terms of that were happening last year, and then there are other parts of the back end. I think you're probably referring to maybe payment issues or those kinds of issues, and we are continuing to work on those. Some of the back end issues are around the IRS issues that we'll be doing, continuing to make progress on each of those issues in a sequenced fashion. As I mentioned before in the beginning, we are prioritizing as we go through, but continuing to make progress on these back-end functions, and whether that's the database lining, which some folks here have asked me questions about before. We continue to work in the case of where it's with insurers, with them, in the case of where it's with our own systems on that.
If I can follow up before we go to the next question, can you give us an update on the people who still needed to get in documentation as of the end of last month? How many people have actually been cut off, and how many people are going to have their subsidies changed because they didn't get their documentation in?
So two different categories. One is the category of immigration documentation and documentation related to that. And we are continuing to process that information, because I'm sure you can imagine that more paper, to the deadline point that was just raised, more paper has come in. Same thing with the income. When we send out the letters that say things will change, that's when we start to get the documents. We're in the middle of processing those. Want to get all of that processed as much as possible before we get to open enrollment. So we'll have final numbers, but the numbers continue to go down from the numbers that we made public. I think what we tried to do, and this is to the transparency point earlier, is put out the numbers. The numbers, 115,000 letters were sent on the immigration front. That number will come down. Similarly, the number of the starting point, it was 1.2 million households that had income issues. Well over 800,000 of those were resolved, and then we sent out letters to that block, and we're processing what we've gotten in.
Have you actually cut anybody off or changed their subsidies?
With regard to the question of the subsidy change and the cutoff, I think in terms of how that will be implemented, it is over a month-to-month period in terms of when their cycles. So I think that actually also has to do with insurers and when they would do that.
Ricardo.
Hi, Ricardo Alonso Zaldivar with AP. And the focus is on people signing up for the first time next year. There's a lot of focus on that. But I wanted to ask you, what are your goals for retention for the people who are already in the system? What are your goals for a satisfying consumer experience for those people, particularly since for many of them, automatic enrollment may not be a good option since their cost of their plan, the premium, and their subsidies are going to change. So can you lay out for us your objectives for retention, both on the consumer experience and the kind of percentage share of retention that you want to see?
So re-enrollment, I think it's important to raise because I think as we think about this system and going through the process, I think people think this is year 2. It's not year 2 because of the point you just raised. This is the first year that we will have re-enrollment and enrollment. So it is the first year through the cycle. And to be honest, when we get to April, it's the first year of the reconciliation cycle. So this is the first full year. And I think the focus on re-enrollment is something that we are equally focused on. As I said earlier, in terms of doing the analytics on the buildup of the question of new enrollment, when I think about the 13 number, or whatever number we think is the right number, we have to derive this number too. And so right now we are working both with the insurers and their analytics on this, as well as our own analytics on what percentage retention we think will be there. That's going to be a part of this overall of what we think our final numbers will be. So don't have a specific number on that, continuing to work through to try and get to the right place. And that right place is based on this is a new product, this is a product, as some reflected, hasn't been used, and trying to get to that right number. With regard to the deep focus on making sure that 2 things happen, that people who want to do auto enrollment are able to do that in the easiest way possible, and that for those, we want to encourage those to go in and shop because that's a part of what the marketplace is. Our communications are targeted toward exactly what you just suggested, which is making sure that people know the importance of going in and shopping. And I think it was outlined yesterday, and I think we're going to spend time and come back and probably, I think Andy Slavitt and Kevin Cunningham will both be talking further about the specifics of the re-enrollment process. But let me say a few general things, which are our communications are going to be targeted on encouraging people to come in because I think we believe that it is best if they can go in and make sure they shop. That is the idea of a marketplace, to make sure you get the best deal. I think yesterday Kevin Cunningham mentioned we want to make this as simple as possible, and doing simplified instructions that are easy, usable, and very simple are an important part of this process. The other thing that I think is an important part of what we're going to do to make sure that the consumer has an experience and makes it easier for them with the question of re-enrollment is making sure that they have alternatives. Different people will want to do this different ways. Some people are going to want to put in their plan and go shop. Some people are going to want to auto-enroll in their own plan. Some people are going to want to use help and guidance. And so making sure that we have different avenues, because one of the things that I think is true and gets reflected as we get into these questions about how people go in and what they do is different people have different needs, and what we're trying to do is meet as many of those consumer needs as we can.
Are you going to prominently tell people who are being re-enrolled that their subsidies might change, their costs might change, they might get a better deal if they shopped?
Yes. Yes, that will be a part of the communication pattern that we will do. And the communication will start with marketplace communication and insurer communication as open enrollment starts. And then we'll go through that period in terms of making sure that people know and understand that. And people who are auto-enrolled will also get communication so that they actually know that they still have an ability to go in and change even after that point while we're still in an open enrollment period.
Diane.
I wanted to know what you're doing in terms of, I'm sorry, Diane Weber, Kaiser Health News. We saw a big difference in states that had an insurer who sort of actively did a marketing plan, like in Florida. These are healthcare.gov states that had an active insurer on the ground versus states like Iowa or South Dakota, where the biggest insurer sat out of year 1. What do you know about insurers' marketing plans to try to reach these customers? And what can you tell us about them? Are they stepping up and planning to put the information out there too.
So with regard to insurers, I think it is the reflection that for those insurers who aggressively pursued market share, one saw the impact and results of what they did. And I think that is something that, it is at least our understanding from our conversations with insurers that they are thinking about. And I think different insurers are thinking about different ways to go about that, both in terms of the issue that was mentioned in terms of re-enrollment, as well as the issue of additional open enrollment. And I think they are, as they would do, is they each have their own marketing plans in terms of how they're going to go about doing it, because it is about competition in terms of how they market. And so it is our sense in conversations with the insurers that this is something that they are each individually thinking about how they maximize.
Are you pulling the reticent ones in? Are you asking for more?
We are encouraging, whether it is our stakeholder partners or our insurer partners, to be partners with us as we go into open enrollment. And that has to do both with re-enrollment and how we communicate. What we're trying to do as much as possible is communicate with the insurers in this case on what we're communicating on, our communication materials in terms of what they will contain, so that they know what we're doing. Same thing with the stakeholders, making sure that people know what we're doing so that their efforts can be complementary in terms of giving people good information about re-enrollment, which is a challenging thing for many people who've never experienced it and aren't a part of an insured population, as well as those new people to the marketplace. So the thing that we're trying to do most is make sure we have clear communication. Joyce.
Joyce Frieden, MedPage Today. One of the things that's come up with the plans on Healthcaregov has been the issue of narrow networks. Some plans offering, only one hospital or very limited choice of doctors. I know some states are developing, or the NAIC is developing a model standard for what constitutes a network, but I wondered if HHS was thinking about putting in any more standards for that.
I think, as you appropriately reflected, the role of the state insurance commissioners in the regulating of the networks is the place where there is the core fulcrum of the point. We want to continue to listen and understand how the marketplace is working. With 25% increase in the number of plans that are coming in, we're hopeful that that's going to increase more competition and diversity of the type of plans that will be in place. It's something we want to continue to listen and understand in terms of how people are behaving in the marketplace, as well as we continue to look at what people are doing in the private marketplace too, the employer-based marketplace, so that we understand actually how consumers are behaving in an existing marketplace as well. We're continuing to do that, but also providing any support we can to efforts of state insurance commissioners if they have questions or need help as they're thinking through how to work on this issue.
Hi, Dan Mangan from CNBC.com. I'm curious, where do things stand in the issue of direct enrollment, having web brokers like eHealth Insurance, GoHealth, Get Insured, being able to enroll subsidy qualified individuals directly without having to go through Healthcare.com, that interface? That was supposed to happen last year. It didn't. We heard multiple promises during the year that it was going to happen. As far as I know, it's not happening on any meaningful scale.
In terms of the exact specifics of where they go through, that's a question I'm going to defer to Andy to make sure exactly what they are able to do in terms of the click-through and whether or not they actually can do it individually themselves, because I want to make sure we get that right. But with regard to the welcoming of the issue of brokers and intermediaries as a part of it, this is part of the system, and we think it's an important part of the system. I think Kevin Cunahan mentioned yesterday that we think it is something that we welcome. I think with regard to our ability to make progress on as many fronts as possible in terms of integrating from a systemic perspective, how we think about what we can and can't do, there is a balance on consumer friendliness and making sure that the functionality is there with regard to making sure that we have the testing space. And so as we've made decisions about what we can accomplish in this year, it is that balance of those two things.
Hi, Tom Howell from the Washington Times. Just want to know if you can give us a status update on some of the states that ran their own exchanges and had kind of a shaky time during the first round. as far as states transitioning to the federal web platform, states that are trying to salvage their own technology, where do you see things at? Is it going to be kind of stabilized in this next go-around?
So there are states, as you're reflecting, in a number of different statuses in terms of what Nevada's doing is different from what Maryland's doing, is different from what Massachusetts. And so each of the states on a state-by-state basis, again, this one is another one that's retail. Because of the difference in each of the states. And so we're continuing to work on a state-by-state basis, and whether that's making sure that the folks in Nevada have an opportunity and how they're going to re-enroll as we work with them, or in the states of Massachusetts and Maryland, and making sure that their systems are ready to function. So we are working on a state-by-state basis to provide the support, and the support is different in each of these states. And so what we do is continue to track it and work with each of them directly. And again, this issue of communication and clarity is one that I think is a tool that we're trying to use from a management perspective in terms of being clear about what our expectations are and making sure we're communicating with them about what their expectations are of us, where we have, what you're reflecting, I think, is that point where we have crossover with these states that have had challenges.
Are you confident that the states that had challenges are all going to work starting November 15th?
We are doing everything we can to ensure, and have asked the questions. We work with them on a day-by-day basis in terms of the different types of progress. For different states, there were different issues, and we continue to work with them on a day-by-day basis.
Right front.
Hi,
Wait for the...
I'm Arthur Allen from Politico, and I wanted to ask a slightly more obscure area of policy, but on health IT. There's been a lot of dissatisfaction expressed by some provider groups, the AMA, about the meaningful use program. And there's also, on the other side, a lot of concern that these health systems and computers and hospitals aren't talking to each other as well as we'd like yet. And I'm just wondering whether things have reached a point that you've considered any sort of, in talks with the ONC or CMS, changing the focus or altering the meaningful use program, incentive program at all?
I think that steps have been taken in terms of some of the issues that were raised in terms of the timetable and trajectory and slope of the line with regard to the issue of meaningful use, because we have heard some of that feedback. And so that is a step that I think has been taken. I think what's a challenge here, and it gets to the core of the issue. What we need to get to is interoperability in order that we can get to the point of, when I first came to HHS, and everyone was meaningful use, those words, the idea that once we can get these systems interoperable, that's when you get the real value. You get the real value as a practicing physician, you get the real value as a consumer, and that's the next step. At the same time, as we're trying to move forward, we're receiving comments and pressure to slow the implementation. And so this is a push-pull as we're going through change. And so what we're trying hard to do with the Office of the National Coordinator for Technology, I don't know the ONC, it doesn't seem to be very meaningful, those who don't follow this as closely as it sounds like you do, but what we're trying to do is get that balance of hearing the input that we're hearing about slow a little, but at the same time move as quickly as we can to getting over the hump, because that's when we're starting to see some of the value of electronic medical records, but the real value comes at that point in time. And that's also the point in time which we're going to see the changes in that will help with reforming the way we deliver quality in the system. And so this is an important part of it. A couple of weeks ago, I spoke with the BRT and did several things around the issue of delivery system reform, and this is one of information, and what you have raised has to be one of the fundamental anchors of that change. So right now what we're trying to balance is that pushback on speed, at the same time continue moving forward.
Thank you.
Thank you. Steve Koff, Cleveland Plain Dealer. On the subject of provider networks,
It can be quite a task for the consumer to go on healthcare.gov and figure out who's in the network, who's not in the network. In fact, you won't find that out on healthcare.gov. You've got to contact the insurers. Not all insurers are equally transparent about that, so it becomes quite a process. You're looking at price. Okay, these plans might be equal, but is my doctor in there? Is the hospital I wish to go to, if I need to go to a hospital, in there? Has there been any consideration of requiring the insurers to be much more transparent about that, to post on their websites, for instance, here are our networks?
Right now, actually, we do ask the providers to list that on their networks. And because these issues are updated, and it is the providers that provide this information, what we do is link to that. That's how we are getting that information, trying to get access to that information for the consumer.
But again, not all are equally transparent, I'm finding.
Continue to work with the insurers on their levels of transparency. I would say this issue is not just a marketplace issue. I think this is an employer-based issue in terms of the entire market, and gets to this broader issue of transparency in the entire healthcare space. And I think as we look, because we are driving and the marketplace has so many questions, we are driving and pushing this. But I think the issue you're raising is an issue, that lack of transparency if there is lack of transparency or varying levels, I think as you described it, is something that is an issue across the board. We're trying to encourage, and because we are doing the links, we're hopeful that that is going to encourage the providers to provide the information for the consumers that they need for decision making. Thank you.
Hi, Jane O'Donnell with USA Today. Doctors and hospitals say that with the increase in high deductible plans that they're seeing people wait longer and longer to get treatment, and they're seeing an uptick in things like later stage cancers. Do you think the middle class is actually worse off while the poor are better off with their plans, and what do you think that's going to portend for the nation's health?
With regard to the evidence of that, that's something that of course we will want to see if there is evidence of what you just described. I think what we do know with regard to the question of the broad middle class, and this is an important part of what the Affordable Care Act did, is in terms of prevention and screenings and the things that actually are very important to preventing some of the conditions you manage, that because of the Affordable Care Act, people will have access to those, and access to those in a number of cases without payment. Without copays, without any kind of thing. So when I spoke earlier about the importance of making sure people understand how to use their health care, that was a comment that was actually not just about those who are newly entered into the marketplace and newly insured. It's about everyone here. Again, the most educated group, I'm in a room with the most educated, and if I asked everyone to write down the top 6 things that you can get to do because of the change in the Affordable Care Act, I think it's a reflection of we do need the education to make sure people know and are taking advantage of that for their own health care. So with regard to the increased access, the other thing is for many women, the issues of plans that could charge more for women because of their different health care, that's no longer there, and I think that's an important middle class issue. For middle class people, if any of you all chose to make a decision to change your employer right now, and there is anyone in your family that has a pre-existing condition, you can now do that without fear that you won't be covered. And so the questions of the benefits with regard to the middle class, and even those who are in employer-based systems, are something that I think we need to spend time focusing on, both in terms of educating people about what it is that are the benefits of the Affordable Care Act. Okay. Jeff.
I'd also like to ask about the consumer experience.
Introduce yourself. Introduce yourself.
I was about to, sorry. I'm Jeff Young with the Huffington Post. A little over a year ago, the president, your predecessor, everybody down the line talked about how wonderful the shopping experience was going to be and how great the website was and how the call centers were all staffed up and people were ready. And that turned out, to put it briefly, to not be the case. So, I mean, what can you say to assure the public that this time what we're hearing now about how the website's better and the call centers are ready is going to be true?
So I want to be clear. I think that what we have said is that the experience will be better. We have said that it will not be perfect. We know that. And we know that there will be issues that will get raised as we go along through the process. In terms of the question of the evidence and where we are, I think what we can say is yesterday you saw an application that is up and running, that was tested since July, that reduces the number of screens from 76 to 16 in terms of an application that, while not everyone can use, and it is for those who are newly enrolling, that we see that we have that and have that in place. The second thing with regard to the experience, because I think there are two elements to the experience, as I've said. One is the actual functionality, which you were reflecting was problematic, as well as the consumer experience. And that's an example on the consumer experience side. On the question of the functionality, I think we've outlined in detail and spoke to this yesterday. I think Andy spoke to it yesterday with regard to the testing that we are doing to ensure that the functionality has that capability, and whether that's the end-to-end testing, the alpha testing, the functional testing, the load testing. And those are the pieces of evidence that I think we reflect. I think yesterday what Andy said is very true. What we want to work on is not talking about expectations, but about results. And that's what we're focused on as we work through this time and this process.
So as Secretary, you're confident that at this point you have a firm grasp of exactly where things stand, what's working, what may not be working yet, that sort of thing. Because part of the issue last year is it seemed like the people at the top of the chain didn't know that the website wasn't going to work.
What I have said and will continue to say is that every day we are working through the deadlines that we have internally to get us to what we have said, which is a good consumer experience for open enrollment. And each day we do that. We work through them on the technological side. We work through them on the consumer experience side.
I think we have time for one more question here in the back.
Hi, Susan Jaffe, Kaiser Health News contributor. If consumers really do the homework and track down which providers are in which plans, providers can and do drop out during the plan year. Other than requiring advance notice, and I'm talking about marketplace plans as well as Medicare Advantage plans, other than requiring some advance warning, what can HHS do to address this problem, especially since so many plans have very limited provider networks? So if your doctor leaves your plan, you may not have a whole lot of options in the middle of the year.
This is an issue that works across the entire employer-based system. And so it is an issue for the entire system. It is not simply a marketplace issue. And that is a decision that providers make. And so our ability to control the insurer and the provider, what we want to do is create a marketplace, and that the competition in the marketplace will drive consumers to make choice and decision. One of the things that we saw last year in terms of what many consumers make their decisions on, and you see it in the private employer place, is actually they do make that decision often based on price. And so as we continue to move forward, we're going to learn, and we want to continue to learn what the consumers are making choices on, and have that inform how we try and shape and influence. But much of this is a marketplace. It is an open market, and that is a part of the system that we have and that we support and work within.
But HHS regulates these plans, so if your doctor leaves your plan, should you be able to leave?
Are you asking the question of should you have a special enrollment period if your plan changes mid-year? A question that I've not heard raised before in terms of that specific issue. As I've said, as we work through this and understand what the consumer actually cares about and wants, those are things that we will incorporate into our thinking.
Thank you very much. I hope you'll come back and do this again soon.
Thank you. Thank you all for having me. Thanks very much.